Dear colleague, I would like to bring to your attention the case of a young nulliparous patient, 28 years old, who came in for a routine gynecological ultrasound. The patient denies any pain symptoms, metrorrhagia, or menstrual irregularities. The examination was started, as usual, via the transabdominal route. The uterus appears to have regular volume and morphology, and its measurements are taken for biometry. The myometrial echotexture is homogeneous, with no evidence of adenomyosis or fibromatosis. The endometrial lining also appears regular, with a hyperechoic echo pattern and a maximum thickness of about 10 millimeters. Next, by moving to a transverse scan, we acquire the remaining two diameters, namely the anteroposterior and the transverse, to complete a uterine biometry that appears regular. We then proceed to examine the adnexal regions. In particular, on the right side, an ovary is observed with volume and echotexture appropriate for the patient's age. In the left adnexal region, a solid neoplasm is immediately evident with regular and well-defined margins, homogeneous and hypoechoic echotexture. The patient reports having undergone a follow-up ultrasound 6 months earlier, during which there was no evidence of this lesion. It appears within the ovary and seems to have an ovarian origin and relevance due to the presence of the typical peripheral crescent sign, that is, the healthy residual ovarian stroma, visible as a small crescent on the periphery and recognizable by the presence of small follicles within it. The lesion is measured and has an average diameter of about 4.5 centimeters. We assess its echotexture. Specifically, the echogenicity appears homogeneous, which allows us to make some differential diagnoses, particularly with cases of pedunculated subserosal fibroma of the uterus. In fact, there are formations that, although having the same echogenicity, that is, homogeneous, may originate from the lateral uterine wall on the same side, protruding into the adnexal region, in this case on the left. However, they usually appear as paraovarian formations, meaning they are not within the ovarian stroma. In fact, here we see that the remaining stroma is measured at about 3 centimeters, but these lesions are adjacent to the ovary and can be clearly separated from it. The echogenicity of the lesion also allows for further differentiation and would make it possible to rule out cases of ovarian endometrioma, since in this case it does not show the classic appearance, that is, the so-called ground glass pattern, which lacks this homogeneity. Let's actually see that. On color Doppler, there are no intralesional vessels present. The color score indicated in this case is type 1. We only see vessels peripherally within the ovarian stroma, but there is also an absence of pericapsular vessels of the pedicle, which would typically be seen in the previously defined fibroma and are not present in this case. The absence of intralesional vessels further supports the belief in benignity, as it would also rule out cases of primary ovarian tumors and cases of secondary tumors, that is, metastases originating from primary tumors of the gastrointestinal tract, stomach, or colon, with metastatic spread to the ovary. In fact, at a velocity of 8 centimeters per second, no intralesional vessels are visible. Completing the examination via the transvaginal route, once again we observe a uterus with regular volume and echostructure, and an endometrium that is also regular, as well as the absence of fluid collections in the Douglas pouch. We then move to the adnexal area. Specifically, we re-examine on the left side the neoplasm already seen via the transabdominal approach. Once again, the homogeneous echogenicity is evident, as is the presence of healthy peripheral ovarian stromal parenchyma, that is, the so-called crescent sign. We proceed to reassess the measurements of the lesion, as well as the peripheral stroma, which is about 3 centimeters. Once again, the homogeneous echogenicity allows for further differential analyses. In particular, the case of an ovarian fibromathecoma could be ruled out, as it actually presents the same echogenicity, that is, a homogeneous echogenicity. However, what allows for differentiation is the symptomatology reported by the patient, namely the absence of metrorrhagia or menstrual abnormalities, which would be associated with fibromathecoma because it is responsible for estrogenic hormonal secretion. And we could also further differentiate by ruling out cases of dermoid cysts as well. In fact, in this case, the echogenicity would typically be heterogeneous, with hyperechoic spots and streaks caused by hair, hairs, and sebum residues, which we do not see here. Once again, on Doppler, we see negativity and the absence of intralesional vessels. This criterion, together with the fact that the adnexal location is on a right ovary that appears perfectly normal, as we can see again in this image, supports a benign condition. Therefore, it rules out bilateral ovarian involvement, which is typical of secondary tumors such as ovarian metastases and peritoneal spread, as in the case of Krukenberg tumors, that is, peritoneal dissemination linked to a primary stomach tumor. Therefore, considering the homogeneous echotexture and the typical ultrasound appearance of the neoplasm, we can lean toward a diagnostic hypothesis, particularly when it comes to differential diagnoses with paraovarian neoplasms, such as, for example, a pedunculated subserosal uterine fibroid. We can also rule out endometrioma due to the typical ground glass appearance seen in the first image, which is not present in our lesion. We can rule out a dermoid cyst because of its typically heterogeneous appearance, striae and hyperechoic spots, which are not visible in our lesion, as well as cases of fibroticoma, as seen in the third image, where we observe similar echogenicity and also the residual peripheral ovarian stroma, the so-called crescent sign. What differentiates this case is the absence of any symptoms reported by the patient. Finally, we can also rule out cases of ovarian metastases, as seen in the last image. These are formations that appear solid and hyperechoic within the ovarian parenchyma, but can be excluded in our case because they show greater and more intense vascularization, with a higher color score of 3 or 4, and typically involve both ovaries, which is not present in the case under examination. Therefore, the most likely diagnostic hypothesis seems to be that of an ovarian fibroma. Thus, the patient is advised to undergo tumor marker testing, a surgical consultation to assess the possibility of excision, and a histological examination. In fact, ultrasound today represents a method that allows us to make a diagnostic hypothesis, but the only real means to establish a definitive diagnosis of the nature of the lesion in question is, indeed, the histological examination. Thank you for your attention.